Good afternoon, everyone. Hi, and welcome to Hopkins. My name is Redonda Miller, and I really have, as president of the hospital, the distinct pleasure of welcoming you all to our institution. As president, I have also had the immense pleasure and privilege of working closely with Congressman Elijah Cummings on a variety of issues, and we are grateful for his steadfast leadership nationally and on behalf of his local constituents here. We are truly lucky to count ourselves among those he has expertly represented for more than 2 decades. And Chairman Gowdy, we are honored to be a part of the House Oversight and Government Reform Committee's efforts to find meaningful solutions to the opioid epidemic. Thank you all for being here today. It is no secret that we are in the throes of a crisis that has reached epic proportions throughout our country, and Baltimore is no exception. In 2016, we averaged nearly 2 fatal opioid overdoses in the city a day. This is a problem in desperate need of thoughtful answers. As both an anchor institution and a steward of health care for our local communities, Hopkins takes this problem very seriously. We see firsthand the devastation that wielded by substance use disorders. Here and at our sister hospital to the east, Bayview Medical Center, the number of opioid overdose patients seen in our emergency departments doubled last year, doubled. This crisis is very much a part of our reality. So what are we doing about it? Well, as an academic medical center, we are addressing the issue through the lens of our tripartite mission of research, clinical care, and education. First, research. Hopkins research runs the gamut from bench to bedside, starting with the original identification of the opioid receptor in the brain by Dr. Solomon Snyder in the 1970s, to the multitude of clinical trials that currently are conducted in our behavioral pharmacology research unit on our Bayview campus. We are working hard to make an impact on the science of the field. Clinical care. We're working on 2 fronts: treating the disorder that already exists and preventing future addiction. In addition to our inpatient treatment units, our Broadway Center for Addiction logs about 25,000 outpatient visits each year. And the program is comprehensive, addressing not only medical issues, but mental health, social service, and family needs. And at Bayview, we have specialized programs targeting pregnant women, youth, and adolescents. Perhaps just as importantly as treating, we are working aggressively to preventing pathways to substance use from ever opening. We've implemented guidelines that emphasize wise prescribing of opioids, such as limiting the doses on first prescriptions, particularly after surgery, and eliminating automatic refills. While patients are with us in the hospital, we have pain specialists work with them to find alternate modalities of treatment for their pain. And we provide access to naloxone for patients with substance use disorder who visit our EDs. But we haven't stopped there. The third part of our tripartite mission, education. As educators, we are working to ensure the next generation of physicians and providers are taught these best practices in treatment and prevention by incorporating them into all aspects of their training. We realize that the work we're doing is just one piece of a vast, complicated puzzle. The opioid epidemic is, after all, a public health crisis that requires a system-wide approach. Among our partners is the Johns Hopkins Bloomberg School of Public Health. The school's Bloomberg American Health Initiative, launched last fall with a generous gift from the Bloomberg Philanthropies, is funding innovative research projects, partnering with community-based organizations, and working with policymakers around the country to implement evidence-based comprehensive solutions. And beyond our Hopkins campuses, we rely on the expertise of so many other health-related institutions and businesses, from the Baltimore City Health Department to our local pharmacies, our payers, and you, our elected leaders. So I look forward greatly to today's testimony from a dedicated and informed group of witnesses. I am confident that your work here will move us forward to achieving solutions to the crisis. So thank you. And now I'm honored to yield the floor to the esteemed Mayor of Baltimore City and friend of Johns Hopkins, Mayor Catherine Pugh.
First, let me say good afternoon to everybody. And to this esteemed committee, thank you for being here. And Mr. Congressman, to both of our congresspersons, I see Congressman Cummins and Congressman Dutch Rupersberger is also here with us. And Mr. Chairman Troy Gotti, thank you so much for convening this meeting here in Baltimore at one of our most esteemed institutions in the world. And so we are really grateful because everybody knows at this point that we are in a crisis. Opioid addiction, we are suffering from it here in Baltimore, but the nation is suffering. And it is important that we pay close attention to what we do as it relates to the individuals who are suffering from this and the communities that are being destroyed by it. And so we know that in Baltimore City we have a big problem, but we know that we are part of a larger problem. I was thankful to our governor who has convened a group to look at this particular issue, and we are focused on not only making sure that people don't get involved with drugs, but doing what we can to keep people from overdosing. I have one of the greatest, I believe, health commissioners in the country, in Dr. Nguyen, who is really focused on this particular issue. So I want to again welcome you all here, and I know that this panel will continue to deliberate over this particular issue, and I look forward to hearing the results of this panel. So we welcome you to Baltimore, but more importantly, we understand the importance of your work, and we look forward to results. Thank you. And now I have the distinguished honor of bringing before you the governor of the great state of Maryland, our governor. Mr. Governor, come on up. Governor Hogan, thank you so much.
Well, thank you, Mayor Pugh, and thank you, Governor Christie. As you know, Governor Christie chaired the President's Commission on opioid, and I want to thank Chairman Gowdy, Congressman Cummings, Congressman Rupersberger, and all of our members of the House for coming here today to Baltimore. We thank you for holding this important hearing here in the city of Baltimore and in the state of Maryland. And also want to thank all of you in the audience for being here today, and those of you who are going to testify before the committee and that have enough interest to be here. This is a national crisis, and it's something that I've been very passionate about for about 4 years. When I first decided to run for governor, I was traveling the state of Maryland, and every single town and community that I would go into, and I would ask the local leaders, what's the number one issue facing your community? And it didn't matter whether I was in Baltimore City or urban areas or wealthy suburbs of Montgomery County in the Washington suburbs. It didn't matter if I was in a small rural town. The answer was always the same in every single place I went. They said the number one problem we're faced with is heroin and opioids. And it came as a shock to me, but during our campaign, we started bringing in folks involved in treatment, in education, interdiction, crime fighting, state's attorneys and police officers, and we got all the input we could. As soon as I was sworn in as governor, one of the very first things I did in January of 2015 was put together a heroin and opioid emergency task force chaired by Lieutenant Governor Boyd Rutherford. They traveled the state and held hearings in every part of our state where hundreds of people would show up to testify and tell their stories of addiction and the problems. And we came out of that with 38 recommendations, all of which we implemented, focused on every aspect of the problem, and it continued to get worse no matter what we tried. We became the first state in America to declare a real state of emergency, just like we would for a natural disaster. And it is a national disaster. Just so far this year in our state, 1,180 people have died of overdoses in Maryland. And almost every single day, people are dying in parts of our state from one end of the state to the other. For the first time ever, this has now evolved from, we've reduced the number of deaths from prescription opioids. We, for the first time ever, have flatlined heroin overdoses. But we have a 70% spike in fentanyl and carfentanil. 850 of our 1,180 deaths are from these new synthetics. So as we all try to wrestle with this issue, it constantly evolves, and so must our effort to fight it. And I just want to thank the Governor Christie for his work, the committee for their work, and the interest and focus on this, because it is a not just a health crisis, but it's impacting and tearing apart families and communities from one end of the country to the other. And it's going to take an all-hands-on-deck approach. The federal government working with the state and local governments, along with people in the private sector and hospitals. I want to thank Hopkins for hosting us today, too. But I want to thank all of you for your interest and say that I called on the federal government back when we did our state of emergency and said the federal government ought to do the same thing. And that would be my recommendation to the committee. We've got to have federal funding. And I would say this is the most important problem facing our country. So thank you all for focusing on it. I'm going to turn over the floor to Chairman Gowdy, who's going to lead the hearing. Thank you so much for being here.
Thank you, Governor. Thank you, Mayor Pugh. Thank you, Johns Hopkins, for pardoning the inconvenience of having a committee of Congress come and appreciating the seriousness of the issue that brings us here. The committee will come to order. Without objection, the chair is authorized to declare recesses at any time. I'm going to break from protocol a little bit because we are in Mr. Cummings' hometown and because he cares so passionately about this issue, we are going to recognize you first for your opening statement.
Thank you very much, Mr. Chairman. And I want to, first of all, just mention one thing that's so important to me, Mr. Chairman, to the members of this panel. I cannot come into this hospital without saying thank you to Hopkins for saving my life. And spent 60 days here this summer, and a lot of it in this building. And so I want to thank, I see a lot of white coats out there and others, but pass the word. I thank you for what you have done for me and my family. I want to begin by thanking Chairman Gowdy for calling today's very important hearing and for bringing the Oversight Committee to Baltimore. I also thank my colleagues for coming to Baltimore, and certainly my colleagues who represent Baltimore along with me is Dutch Ruppersberger and John Sarbanes. I thank you for being here. I've been in the Congress now for 20 years, and I've been through and seen a lot of field hearings. I've never seen as many members attend any field hearing since I've been in Congress. I believe today's remarkable turnout reflects the fact that the opioid crisis is truly a national emergency. It does not discriminate based on politics. It affects red states and blue states and every state in between. So I'm extremely grateful that the chairman agreed to my request to bring the committee on the road to investigate the devastating effects of this very difficult problem. I also want to thank Dr. Miller and Johns Hopkins for your warm welcome and your hospitality. The work that you do makes a huge difference in our community and around the globe. I also thank our esteemed guests, Governor Hogan and Mayor Pugh, for joining us. We are honored to have you in our presence. And of course, I thank our witnesses, Governor Christie, Commissioner Wynn, Dr. Alexander, and Mr. Baum. Thank you for testifying and for all that you are doing to help us combat opioids and save lives. A year and a half ago, at our committee's first hearing on this issue, I warned that so many people were dying in communities across America and that we could no longer ignore this emergency. Today, the Centers for Disease Control and Prevention estimates that more than 64,000 Americans died from drug overdoses in 2016, an increase of more than 20% over the year before. To put this in perspective, the death toll from drug overdoses last year alone was higher than all U.S. military casualties in Vietnam and Iraq wars combined. Every 20 minutes, someone dies from an opioid overdose. If today's hearing lasts for 2 hours, half a dozen families will have lost a parent, a sibling, or a child to opioids. We have the reports. We've had years of talk. Now it's time for action. The American people are looking for us to take action. They're looking to the President and the Congress, and they're asking, what are you going to do? Governor Christie and the other members of the President's Commission on Drug Addiction have given us an excellent blueprint for action with dozens of recommendations. Now it's up to us, Republicans and Democrats, federal, state, and local officials, researchers, policymakers, doctors, drug companies, health providers on the ground, and families of the faith communities. We need to work together to end this epidemic. There's some things that we can do right now to help prevent addiction and save those who already have this disease. For example, we can ensure that every single person who needs naloxone has it. The Commission's report highlights the importance of equipping first responders with naloxone, including police officers, fire departments, and public health officials. But here's the challenge. Drug companies have continued to hike the price of this 45-year-old drug, and communities have been forced to ration it. In September, I led 50 members of the House of Representatives in sending a letter urging President Donald Trump to negotiate lower prices for naloxone, just as the Commission recommended. Unfortunately, we never received a response. The President should act now to ensure that naloxone is available at a reasonable price whenever it is needed. We also need to ensure that every affected person has access to effective treatment. According to the Commission, and I quote, today only 10.6% of youth and adults who need treatment for substance use disorder receive that treatment. Only 10%. There's simply no way we will end this crisis of 90% of those affected are not being treated if we do not act now. To do this, we need funding. Last month, President Trump declared this epidemic a public health emergency, but he did not propose any additional funding to combat it. We cannot fight this epidemic without funds equal to the challenge we face. This is the sad but stark truth. So finally, we must recognize and acknowledge the many factors that put people at risk. Woefully inadequate support for our children and our vulnerable residents, worsening economic inequality, lack of opportunity, and profound disparities in the criminal justice system. We cannot solve this crisis until these risk factors are addressed. With that, Mr. Chairman, again, I thank you for convening this critical hearing, and I look forward to the testimony and taking action on it. And I ask, Mr. Chairman, with the unanimous consent, that Representative Ruppersberger from the state of Maryland and Representative Sarbanes from the state of Maryland be permitted to sit in with the committee and participate in this hearing today. And with that, I yield back.
Without objection, welcome to our colleagues. I also want to thank the Johns Hopkins community for taking such great care of our friend and colleague over the summer. You sent him back stronger than ever. So thank you all for whoever had a role. You didn't have to send him back quite that strong, but you sent him back stronger than ever. Governor Christie, Governor Hogan, recent, past, and present governors have witnessed the most devastating drug epidemic in our nation's history. Since 1999, more than 500,000 Americans have died from a drug overdose. And the epidemic is escalating. Over the span of nearly 20 years, the death toll has quadrupled with the emergence of even more potent drugs and an ever-expanding online market for illicit distribution. Today, drug overdoses kill more Americans than gun homicides and car crashes combined. That is a staggering reality. 2 out of every 3 daily deaths from drug overdoses in the United States involve an opioid, a class of drugs commonly prescribed to relieve and manage pain. Nationally, over 33,000 Americans died from an opioid-related overdose in 2015, which is an 11% increase from the year before. In South Carolina, where I come from, Greenville and Spartanburg counties in particular suffered more than 100 opioid-related overdoses in 2015, and while the numbers in the upstate of South Carolina are fewer when compared with cities like Baltimore, behind every number and every statistic is a life with loved ones and friends and potential and aspirations. We have a tendency to use numbers in government and in our line of work, but the victims aren't numbers. The victims are fellow human beings ravaged by the consequences of drug addiction, including the abuse of prescription painkillers. We are a remarkable country of progress and innovation, community, and charity. We can cure diseases that past generations lived in fear of. We can put people on the moon, and we can split atoms. Yet we're struggling with how to respond to this epidemic. $20. I guess we need to start with how did we get here? There are more illicit uses for these drugs, and there are illicit uses for these drugs, and there are illicit uses for these drugs. One is unlawful, of course. The other is legal, but with the potential for abuse and misuse remaining. Physicians have a role to play for certain. These drugs are not available legally without a prescription. What are the pharmaceutical alternatives? Is there overprescribing? Is there sufficient information shared with patients to avoid misuse and abuse? Frequent exposure and easy access to painkillers has led to dependency intolerance, which drives those with a substance use disorder to intensify doses or methods with or without the help of a physician. Addiction to prescription painkillers is growing exponentially. On the illicit side of the equation, malevolent actors are diverting high-potent pills to the black market to be laced with heroin, resulting in drugs so lethal they have been called gray death, term used to describe the high risk associated with every single injection. Opioid-related overdoses are now deadlier than the HIV/AIDS epidemic at its peak, more insidious than the cocaine-based cocaine powder epidemic that predated it. So there are a plethora of questions to be asked, such as whether we are being as effective as possible in the diversion of these highly toxic substances. I actually like doctors. I happen to be the son of one. But I also prosecuted doctors. And I want to make sure the DEA and DOJ are effectively going to the source of prescriptions issued outside the course of a professional medical practice. Is HHS monitoring insurers placing pricier but less addictive opioids out of reach for patients with acute pain? Are states regulating so-called sober homes, which can move vulnerable patients in and out of treatment, typically for profit? These are the questions our committee and the American people want answers to. The health and safety of our communities all across the nation are at risk. Although almost everything seems capable of being reduced to political exercise in our current environment, I genuinely hope that this epidemic is above that. I hope it's about protecting those susceptible to addiction and punishing those fueling the epidemic. Death, especially the premature death of a young life, has no political or ideological bent. Victims are victims, perpetrators are perpetrators, addiction is addiction, heartache is heartache. The issue to me comes down to those of good conscience earnestly seeking a solution and those of a malevolent conscience bent who profit off of other people's addiction and pain. It's not just the deaths that devastate our families and communities across the healthcare system. It's also the disease of addiction that is permeating and threatening in some places within our country the very fabric of those communities. At the same time, pain is real. It is real for a home builder in Mr. Cummings' district or mine with immense back pain. He can't otherwise get out of bed in the morning without his physician-prescribed pain medication. So how do we solve this epidemic? There's a prevention aspect, there's a treatment aspect, there's an education aspect, there's an enforcement aspect, there's a punishment aspect, and there's an oversight aspect. In March, the President signed an executive order creating a commission consisting of governors, an attorney general, mental health advocates, and a professor of psychobiology to recommend policies for the federal response to this epidemic. And earlier this month, the commission finalized recommendations for how the federal government can help states and stakeholders tackle the evolving crisis, and stave off emerging threats. Today, we'll have an opportunity to highlight the report, and in Baltimore, and appropriately so. We will also examine Baltimore state and federal partners and how they can assist with and learn from the efforts that are occurring here. The devastating statistics may leave us feeling like we have just left the start line. But our country is resilient, and we have resources, we have compassion. I think we have the commitment to win this battle with opioid and opioid addiction. So I want to thank all of our witnesses. Governor Christie, you are the governor of the great state of New Jersey. As I mentioned to you in the anteroom, you're also a former United States attorney, so you are uniquely well suited, and we cannot thank you enough, not just for your presence today, but for your willingness to undertake this vitally important responsibility and role. And with that, you are recognized.
Thank you, Mr. Chairman. Ranking Member Cummings, thank you for your work in this area, and thanks to all the members of the committee for inviting us today. As the chairman mentioned, in March, the president asked me to chair his commission on opioid and drug addiction in our country. We worked together to name a bipartisan group of people to join that commission, and I think that's an important place to start. I could tell you, as the chairman referenced in his remarks and Mr. Cummings in his, I am acutely aware, as a Republican governor in the state of New Jersey, that there is much that divides political dialogue in our country right now that makes it very difficult for us to get things done. This cannot be one of them. I read the obituaries that are happening regularly in our state, and in none of the obituaries do they designate whether the person who died was a Republican or a Democrat. They're a son or a daughter, a husband or a wife, a mother or a father. And so I hope that what we tried to do in the commission and this committee is trying to do today will help to give this problem the ability to rise above the partisanship that we have in our country today. It is true this is the greatest and broadest public health epidemic of our lifetime. Everything else pales in comparison to the breadth of this problem. It is everywhere in America. 175 people are dying per day, which for someone who comes from where I come from, the most powerful analogy is that this means that we have a September 11th every 2.5 weeks. Every 2.5 weeks. Now, I want to ask all of you and ask this committee, if we had a terrorist organization that is invading our country and killing 175 of our citizens every day, what would you be willing to pay to make it stop? We don't ask that question in this country. And the reason we don't ask this question, in my view, is because we still believe that this addiction is a moral failing. We are making moral judgments on the people who are suffering and dying, and we're making moral judgments on their families. Every time I go to a drug treatment center in my state, and I ask someone who's in the midst of treatment, tell me your story. Within the first 2 minutes, they say to me, but Governor, I'm from a good family. And my response always is, why would you think I would think otherwise? The reason why they believe that is because the stigma that is attached to this disease each and every day makes people believe that they have to defend their very upbringing, their performance as parents, their role as a child. That somehow we believe that this is a choice. I would love to see a show of hands in this audience who has not made a bad decision in their life. Usually works. Fact is, we all have. Many of us in this room are fortunate that bad decision was not to abuse opioids or heroin, because if it had been, we might be in a very different judgment position than some people are today. Addiction is a disease. It is a chronic disease, and it needs to be treated as such and viewed as such. That's why I'm proud that the president declared this a national public health emergency. Now, as Mr. Cummings mentioned, we need to fund the Public Health Emergency Fund, which by my last check was at $66,000. I don't think that's going to make it, everybody. in combating this problem. We need to fund the Public Health Emergency Fund to make sure that the administration has at their disposal the resources that they need to implement the recommendations that the Commission has made. We had lots of discussion in the opening remarks about the role of physicians and healthcare providers in all of this. Let me be very clear. This is a drug epidemic that did not start on the corners of Baltimore or the corners of my hometown in Mendham. They started in doctors' offices and in hospitals across this nation. And while some of it, as Chairman Gowdy implied in his remarks, are done by folks who have bad intent, most of it is done by folks who have no intent. Why do physicians and healthcare providers have no intent on this issue? Because they're not educated on this issue. Broadly across our country, in medical schools, in every state in the union, we are not educating our future doctors and nurses, dentists, on the dangers of these drugs. We grant DEA licenses to write prescriptions for these drugs without requiring continuing medical education on opioid addiction and how it can lead to heroin addiction. I, as a lawyer, recovering lawyer, but a lawyer nonetheless, I have to, even as governor today, I have to take continuing legal education every year to maintain my license. And I'm not practicing. How is it that physicians can have a DEA license and not be required to have continuing medical education on this very problem when 64,000 people died last year? The Commission recommends that we do that. And if you don't believe that limits on opioid prescription length as an initial prescription work, with exceptions obviously for people who are terminal from cancer and in hospice, let me tell you what's happened in New Jersey just since we put a 5-day limit on opioid prescriptions beginning on March 1 of this year. Opioid prescriptions in New Jersey are down 15% from March to October, and the number of pills are down 20% that have been prescribed in just that 7-month period of time. Those restrictions work, and they should be instituted in every state across this nation, and that is also in the report. I want to commend the President for granting waivers to states now for the old-fashioned, antiquated, and ridiculous IMD restriction, Institutes of Mental Disease. It says that if there's any hospital healthcare provider that has more than 16 beds, 16, that those folks cannot be reimbursed for the federal share of Medicaid because they are a state psychiatric hospital. What that means is there are literally thousands of beds that could provide the treatment that Chairman or that Ranking Member Cummings recommended in his remarks that could begin to take that 10.6% number up significantly, but are not opened because of this antiquated waiver. States have been asking for this ability to waive this for years. I commend the President for ordering that to be done. And tomorrow in New Jersey, the head of CMS will be coming to New Jersey with me to announce that New Jersey has received their waiver and that hundreds of beds will open within the next 6 months for people who need drug treatment. And these are folks who are the neediest in our society, those folks who qualify for Medicaid. We need to increase physician education across the nation, and we need to decrease the influence of the pharmaceutical industry on that education. See, right now, most doctors only get their education from the very companies that are producing the pills that they want them to prescribe. Now, as Chairman Gowdy said, I am a former prosecutor, and that makes me a little bit skeptical. And I'm from New Jersey, which makes me completely cynical. And so what that tells me is, if the only education physicians are getting are from those people who want them to prescribe these pills, and that in 2015, 259 million prescriptions for opioids were written in this country, enough to give every adult in this country their own bottle of 30 pills. 259 million. We are 4% of the world's population, and we consume 85% of the world's opioids. don't think that that's where this problem has started, listen to the CDC, who says that 4 out of every 5 new heroin addicts began with prescription opioids. We need to have alternatives to opioids because, as the chairman said, pain is real for many people in this country. But that's where the pharmaceutical companies should be spending their money, not on paying doctors to write more prescriptions for opioids. And so that's why we as a commission brought together Dr. Francis Collins, the head of NIH, and all of the executives of the major pharma companies in this country, in New Jersey, and got them to agree to a partnership where they will now work with NIH to come up with 2 different solutions to this problem. First, more non-opioid painkillers to be put on the market and be affordable. And second, more alternatives to medication-assisted treatment for those who are already addicted. Right now, we have 3 in this country. There should be more. Those pharma companies said they have 43 different compounds among them that could address either or both of these issues. Yet they're not moving forward. We need NIH to be the accelerant for moving them forward. And I would urge this committee to look at additional funding for NIH specifically for that program to make sure that we work in partnership with the pharma companies to get these things to market along with the FDA as quickly as possible. If people have an alternative to opioids, both the physicians who prescribe these things for pain and the consumer who wants to avoid addiction, we have non-opioid alternatives, that will be enormously helpful in stemming the tide here. The insurance companies play a large role in this as well. Now, as a governor, I get folks all the time saying to me, well, why don't you change the regulation of insurance companies to make sure that they're covering drug treatment so that middle-class folks in our country who have employer-provided health insurance can get treatment, when right now most of them do not. And I say, well, remember this. Only 30% in my state of the health insurance policies, employer-based health insurance policies, are regulated by the state of New Jersey. 70% are regulated by the federal government under ERISA. So we say, why doesn't the Department of Labor step in? Well, they don't have the authority to do it. Under the statute that Congress passed in the Mental Health Parity Act, they do not allow the Department of Labor to fine an insurance company or an employer who is not treating mental health and addiction with parity, and they do not allow the Department of Labor to investigate individual insurance companies. They must go employer by employer. How ridiculous is that? We urge the Congress and the Commission to give the Secretary of Labor both the authority and the responsibility to fine insurance companies that are not treating addiction with parity to all other diseases, and to give the Secretary of Labor the authority and the responsibility to be able to investigate insurance companies directly, not have to go employer by employer by employer, when we know that we have a number of very large insurance companies in this nation that cover thousands of employers. As a former prosecutor, I can tell you, one robust investigation is a lot easier to staff than 2,000 little ones, and much more effective. Lastly, and then I'll leave it for questions because I could go on for a long time, drug court is a very important part of this. We need alternatives to incarceration. We have put forward in New Jersey the largest criminal justice reform in the last 2 years of any state in America. And one of the things that we've done is institute drug court in every county in our state. What does it mean exactly? When you come in, not as a dealer, not as a violent actor, but as a nonviolent possessor, an addict, you are now in New Jersey required by law to go to drug court, and you are diverted to treatment, not to jail. Now, if you don't take your treatment seriously, and the judge decides that you are not utilizing the opportunity that's being given to you, they'll then send you to jail. But you're going to get a chance first to go to treatment. We should have drug court, and the commission recommends this as well, in every federal district in this nation. One judge in every federal district committed to dealing with the drug problem in this country, to diverting people into treatment, and to giving those families and those addicts who are suffering from this disease hope, an opportunity to get better. I'm a former prosecutor. I'm all for jailing people who profit from this poison. And I'm in favor of putting them in jail, whether they're standing on a street corner in any town or city in this country, or whether they're standing in a hospital or in a doctor's office. If you're running a pill mill and you have a physician, you should go to jail just as soon as this drug dealer on the corner should go to jail. But we will not solve this problem by incarcerating addicts. And we must get them the treatment that they need to be able to have the tools to recover. In New Jersey, we have now been the first state in the country to convert a state prison into a drug treatment facility. And so now, state prisoners who are in their final year of incarceration, who have a demonstrated drug problem, transfer from a standard state prison to the state prison treatment facility that we have on the property of Fort Dix in New Jersey, run by a certified addiction treatment company that works in conjunction with our Department of Corrections to give people the tools to deal with their addiction before they leave prison, so that when they get back on the street, we lower their chance for recidivism. All these things are in the report recommended for states and the rest of this country. We are proud of Governor Baker, Governor Cooper, Attorney General Bondi, Congressman Kennedy, and Professor Madras, who joined me on the commission and worked in a completely nonpartisan manner to make these recommendations to the president. And I hope that the members of Congress work with the president and hold the administration and each other responsible for getting something done on this issue. Thank you. I'm happy to take questions.
Thank you, Governor Christie. We'll now recognize the gentleman from Maryland for his questions.
Thank you very much, Mr. Chairman, and thank you, Governor Christie. I want to, and as I said to you before the hearing and now, an excellent report. I want to talk about naloxone a little bit. I had a situation, Governor, where not very long ago I was at an event for the Maryland Legislative Black Caucus, and I walked outside coming out of the event, and somebody just dropped a man right in front of the hotel. And I said, well, what's going on? They said, well, this happens all the time. We see people who may be at a party, and they don't know, the person has an overdose, and they don't know what to do. And I use that as an introduction with regard to naloxone because, of course, as you well know, it's a drug that has been used to save lives with regard to overdoses. And in your report, you all say, this is what you said, price increases of the various forms of naloxone continue to create affordability issues, preventing state and local governments, as well as community organizations from stocking naloxone at the levels necessary to rescue more people from the overdose. Is that correct, Governor?
That is true, sir. Yes, and what we recommend in the report is that governments, starting with the federal government, should band together to use their purchasing power to make bulk purchases of naloxone at lower prices. And there is no reason why we do this in many other areas of bulk purchasing, whether it's through the GSA, as you know, or through other entities to be able to do this. And there's no reason we shouldn't be able to do this with naloxone. And one of the things we're doing in New Jersey, which we also recommend in the report, is co-prescribing. When you are a physician, you prescribe an opioid, to prescribe at the same time naloxone to go to the home. Because some of these overdoses are not intentional, they're accidental. Someone who's in severe pain thinks, well, if 2 pills every 4 hours is good, 4 pills might be better. So it's not just for the person who's suffering from addiction. It's also from the person who unintentionally misuses this to have naloxone available in the home so that, in an easy form, so that the folks who live with them, if they have an overdose like the one you mentioned outside the hotel, it's in its nasal form now, it's very easy. It's 2 pushes of a button. One in one nostril, push the button. One in the other nostril, push the button, and you save a life.
You know, our health commissioner who will be testifying in a few minutes is one who has been very strong on his Dr. Wynn here in Baltimore. You know, but the thing that I think bothers me so much about naloxone is that the price was jacked up, I mean, big time, when at the very time when first responders and others were trying to get it because they saw the effectiveness of it. Did you have discussions with any of the manufacturer or drug companies with regard to naloxone?
We did not in terms of the pricing issues,
Okay.
Congressman. What we did, though, talk about was the concept of bulk purchasing and their willingness to consider the idea of bulk purchasing lowering prices. And so we did talk about that with the manufacturer, with a few of the manufacturers, and that's why we urged it in the report. We believe it's something that can be done and that these manufacturers recognize, and the Commission emphasized to them, their social responsibility.
Now, that negotiation recommendation that you just talked about was in, I noticed it was in the interim report, but I didn't see it in the final report.
This is some confusion. The way the executive order was written, Mr. Chairman, was that the President wanted first an interim report and then a final report. They should not be read as mutually exclusive. They should be read together. And so if there's, I think, 56 recommendations in the final report, there's 9 in the interim report, we've made 65 recommendations. So the 9 interim recommendations remain fully in force and effect and should be added to the final report.
Good. Well, I'm glad you clarified that. I thought you just kind of changed your mind.
No, sir. I think you know me well enough to know that changing my mind would be a difficult thing. Listen, I reminded the White House on a regular basis, and you need to know this.
My last question is
this was our report.
My last question is this. Have you discussed this report at length with the President? In particular, have you discussed this naloxone recommendation?
Yes, I have discussed.
And what response did you get?
I did not. Let me fully answer this, sir. We have discussed the report at length. I have not discussed the specific pricing issue on naloxone. My conversation with the President was more on how important it was for all law enforcement officers and first responders to have it. But we did not get into the pricing part of it in my conversation directly with the President, but I have had that conversation with other members of the administration.
Thank you very much, Mr. Chairman.
Thank you, sir.
The gentleman from Maryland yields back. The gentleman from Wisconsin is recognized.
Sure. A couple questions. This is really a horrible thing. I think it's a very publicized problem, and it's still underpublicized. Did you look at other countries who perhaps do not have the opioid problems we have? I'm thinking this. I was in Taiwan like 10 years ago, and they had almost no problem. I think England has a big problem. Could you comment on the criminal justice systems and how they deal with possession or sale of opioids in other countries?
You know, we didn't look at it from a criminal justice perspective. What we looked at it from was an availability perspective. And the biggest difference we see between our country and the others is the extraordinary overprescribing of these drugs. We believe that part of it was caused by the federal government, quite frankly, with this, pain as a vital sign requirement, where everybody who leaves a hospital has to have the smiley face, on their lack of pain, and that hospitals were evaluated on this basis. And so what was going on was hospitals said, well, heck, if we're going to be evaluated on this basis, you're going to leave with no pain. And the best way to leave with no pain is to give you a whole bottle of Percocet and get you taking it. And so the difference is the way, at the very base of this problem, we're dealing with the availability of this medication.
Okay. Do you know anywhere where I would even be able to get access to how they treat possession or sale of opiates in other countries that don't have this problem?
Sure. We and the Commission can be very helpful in that regard because we dealt with a lot of other countries on those issues, but not on the particular one you're talking about. But we'd be happy to be helpful. You get your staff in touch with ours, we'd be happy to help.
Yeah. Next question I have, what percentage of people who are arrested for opiates, heroin or whatever, are addicted, and what percentage is using it?
I don't know the exact numbers, Congressman. What I will tell you is that the rate of addiction in terms of the amount of time that it takes someone to get addicted to these, according to the CDC, is as little as 3 days. So if you have a predisposition to this, within 3 days, of your use, you can become addicted, which is why the CDC says their recommendation is to limit prescriptions to no more than 3 days on initial prescription, because they think beyond 3 days you can become addicted.
Have you talked to anybody who when you talk to people who are arrested for heroin, do they say they were addicted in 1 or 2 days?
I will tell you that this young woman, yes, the answer is yes, and I've spoken to literally hundreds of people across my state in treatment centers about this, who say that the time for addiction is very brief. I will tell you that one young woman who is a part of our public advertising campaign on this issue in New Jersey, it's a young woman who suffered an injury, a knee injury. She used her first bottle of pills. This young woman who was a college graduate, cheerleader in college, went out and had her first job, and she was addicted within the first week that she was on these drugs. She went from being employed, having her own place to live, supporting herself, to within 60 days, having lost her job, moved out of her apartment, and was living on the streets of Atlantic City, New Jersey, and prostituting herself to get heroin.
Okay, I'll give you one more question because I don't see it. We normally, as you know, in these committee hearings have a clock, but I don't. In Vietnam, as I understand, heroin was somewhat widely used. And something has been said about how quickly it was not used by the troops once they got back in the United States, which would be a little bit inconsistent with the idea that heroin is always addicting. Could you comment on that?
Yeah, I don't think anything is always addictive to anybody. I don't think it's always addictive, sir. I think there are people, as we know, who use prescription opioids and some who use heroin, who use it and can use it recreationally and not become addicted. So I think we got to be very careful about using the phrase always or never in this context, because you are dealing with human beings who have different genetic backgrounds and makeups, different psychological and makeups, and different physiological makeups. And I think any of the physicians who are here at Johns Hopkins would tell you this is what makes what they do in art as well as a science. And so, no, there's no always on this, sir. But what I would tell you is that when CDC says that 4 out of every 5 heroin addicts start with prescription opioids, and we were talking about the same compound, this is something that is lethal in terms of its ability to become addictive.
I'll give you one more question.
Sure.
Well, the red light, if you're wondering where the lighting system is right there in front of Governor. Although I am in such a charitable mood, if you do have one more short question, emphasis on short.
Sure. One of the questions, or one of the things on treatment is, of course, some people feel that treatment is frequently ineffective. Could you give us your opinion of what constitutes ineffective treatment, or how we can avoid ineffective treatment?
Well, what constitutes ineffective treatment is anything that's not evidence-based. And so we should not be operating theoretically here, and there's no reason to, because there's sufficient information across this country in the medical community about what works and what doesn't. And medication-assisted treatment works for most people who try it. The fact is, though, that the way to make sure that ineffective treatment isn't happening is through the state regulatory bodies who regulate. The departments of health across this country need to be very vigilant about regulating what happens in treatment centers. And there are places in this country where you have a lot of fallacious treatment. I don't want to be the first to shock you and say that there is fraud in all different areas of our country when there's money to be made. It does not discount the value of treatment. What it does is it increases the need for regulatory bodies and prosecutors to go after those people who are ripping off people by giving them false hope with fake treatment.
Gentlelady from the District of Columbia is recognized.
Thank you very much, and I want to thank you, Mr. Chairman, and the ranking member for this very important hearing. And I want to thank you, Governor Christie, for coming and for your very forthright report, which minces no words. The last Congress and the last administration did come forward with $1 billion, but we've seen no slowing in this epidemic. Indeed, my own district, which is not considered one of the most serious districts, the District of Columbia, tripled in this opioid crisis in just 2 years. The this notion of a national emergency versus a public health emergency has emerged. And I note, Governor Christie, that the report indicated that this was a national emergency. Is that not the case?
Well, no, what the report indicates is we believe it's a national emergency that can be addressed one of two ways. Either through the declaring of a public health emergency under the Public Health Safety Act, which was our preferred method, or the declaring of an emergency under the Stafford Act.
And why did you prefer one to the other?
Because of who would administer the funds. If it's under the Public Health Safety Act, the funds would be administered by the Department of Health and Human Services. If it was under the Stafford Act, it would be administered by FEMA. Having had a little experience with FEMA during a small storm in New Jersey, I would just tell you that I don't believe, based on my experience, that FEMA would be necessarily the best folks to administer these funds, and that the folks at Health and Human Services would be better. That's why we made that. We gave the president an alternative because we felt our job was to present alternatives. But I can tell you that my recommendation to the president was to do it under the Public Health Safety Act, so the funds would be in the Public Health Emergency Fund, therefore administered by folks who I think, with no apparent disrespect to FEMA, that would have a greater sense of expertise on how to deal with this issue at HHS rather than at FEMA.
I can see that bureaucratic difference may make a difference otherwise.
Especially if you're a governor who dealt with FEMA, it makes a big difference.
But this region where we are now, Maryland, Virginia, the District of Columbia, just had a summit on this issue. Governor Hogan has declared a national emergency or a state emergency here. I'm trying to find whether the declaration of a national emergency would encourage Congress to, in fact, come forward with some of the funding that you indicate that you thought was necessary. I mean, your remarks were replete with versions of funding one way or the other. You asked at the beginning of your testimony, what would we pay a terrorist, for example, who invaded our country, and making that analogy to what opioid has done. You have called in your testimony for funding the Public Health Emergency Fund,
right,
again, for funding NIH. But we sit here, and Congress is frankly lost focus here. In fact, we're not sure whether the government is going to be kept open, and therefore nobody's thinking about this issue. Would declaration of some kind of emergency force this back to the front burner of the Congress of the United States, which has not funded anything since last administration funded $1 billion in additional funding for this emergency?
With all due respect, I think if Congress needs different wording to focus its attention, then we need.
And what would you suggest?
Then we need a new Congress. Because if you can't tell from 64,000 Americans dying a day that this is an emergency because the president did it under the Public Health Safety Act as opposed to the Stafford Act, then I would say to members of Congress on both sides of the aisle that you need to reassess from a governor's perspective what you're doing. And I recognize the $1 billion that the last administration, the last Congress put in. Let me put that into some context of what's needed. In New Jersey this year, we are spending $500 million.
Of your own money?
Yes, state money, $500 million. And so I am not, quite frankly, impressed with $1 billion from the federal government for the nation when the state of New Jersey is dedicating in a $34 billion budget, we are dedicating $500 million just to increasing availability for opioid treatment, training, naloxone. All of that is being supplied by the state to localities. Now, we need help from the federal government, and I want to be clear about the public health emergency. It is a national emergency. It's just two different ways of doing it, whether it's under the Public Health Safety Act or the Stafford Act. And my recommendation was the Public Health Safety Act to keep this away from people who don't know about this problem. There is confusion about all this. And you want to see real confusion? Let's put FEMA in charge of naloxone. As somebody who was waiting for blankets and food and water in Sandy, I don't want to be waiting for FEMA to give me naloxone.
Thank you very much. I
Thank you,
have the red light.
Thank you, ma'am.
Gentleman from Alabama is recognized.
Thank you, Mr. Chairman.
Gotta turn it on.
Does that work?
Yeah, there you go. Now we can hear you.
Is the clock started now, or did
It
it,
just started.
or did it start after my
Only
colleague
an
turned off the
Alabama
microphone?
guy would ask me to
In
restart.
good shape.
Yeah.
Yes, we're
Okay.
restarting because
right.
of the Iron Bowl and how upset you are.
There you go.
Don't go there.
It's worth at least 15 seconds.
All right. I just want to go back to something that was brought up by my colleague from Wisconsin about heroin and as an initiator versus the over prescription of painkillers. And what we found is that the opioid addiction is initiated by painkillers like oxycodone and hydrocodone has actually gone down. It dropped from 42.4% for oxycodone to 27.8. I mean to 24.1, and from 42.3% for hydrocodone to 27.8. But in terms of heroin as an initiator, it's gone from 8.7% in 2005 to 33.3% in 2015. So I think we're on two tracks here, Governor, that I think that the medical community has to address, but also the law enforcement community has to address.
Oh, no question. And the report,
be a tandem effort.
right, the report talks about that. There's no question that we need to make sure that enforcement against those, and I think I said this in my opening statement, that as a former prosecutor, enforcement against those who are profiting from the poison that they're spreading throughout our communities has to continue, and has to continue aggressively. And so I don't think there's no reason you can't chew gum and walk at the same time. Fact is that we also need to acknowledge that treatment as a part of what our overall spend is across the national government and state governments is a fraction of what we spent on enforcement. And so I want the three-legged stool to operate. I want there to be education prevention, interdiction, and law enforcement and treatment. But right now, the prevention education part and the treatment part are shorter legs of that stool. And as long as that continues, we're going to continue to have this problem. But you will not find me being opposed to stricter enforcement against those who are profiting from this. But we must draw a distinction, in my view, between those who are profiting from it and committing violent acts in support of it and those who are addicted without those other elements. Those people, I think, in the criminal justice system need to be dealt with differently than those who are profiting from it.
I also think we need to look at this in a holistic manner. I don't know anyone who doesn't know someone, either a friend who has a family member who hasn't lost someone to an opioid overdose. It crosses every boundary that you can think of: race, gender, income level, profession. But one of the interesting things is that doesn't get talked about is family structure. And when you take a look at that, 68% of the population is either married or widowed. Yet that only represents 28% of the overdose deaths. Whereas the never married and divorced population is about 32%, but they represent 71% of the opioid overdoses. I would like to see us do a deeper dive into that to start looking at the ages in those categories. But I think that's got to be part of the discussion, is the overall breakdown of the family and how that has contributed to this.
I think as a father of four, married for 31 years, I believe we're doing something right. At least we're trying to. But I also want to be very careful about this as well, because there's plenty of folks who are in the situation I am who wind up having children who wind up addicted. And so there's part of what we said in the report is there's not one silver bullet to fix this problem. It just isn't. And whether it's the issue you raise or treatment or interdiction. So I think all those things have to be considered and looked at as part of what's leading our country to consume 85% of the world's opioids with 4% of the population. So there's something happening all across our country that is encouraging this. But there's no question that all those things have to be things that are considered. But I don't want to mislead anybody that there's one silver bullet to fix this, because there is not.
Well,
I'm confident.
from my own personal experience, one of my children's classmates, a tremendously talented young African-American artist, died of an overdose. And then one of my board members of the think tank that I ran, I literally sat in their living room with them while the local authorities removed the body of his son from his bedroom who had died. My last point, Mr. Chairman, if I may, is taking a look at the drugs prescribed through TRICARE and through the VA. I've gotten information from different people about the tremendous numbers of drugs and that are sent out that these people don't need. This is a huge issue in Alabama. It gets back to where we started, or where I started with you, the overprescribing of medicine. If you'd like to address that.
That's a large part of the diversion problem, right? So that's why we've advocated in the report, and it's happening, and it's a good partnership with the private sector as well, places like Rite Aid and Walgreens and other major national pharmacy chains that are setting up kiosks in all their stores for people to safely dispose of these unwanted or unused medicines. A lot of times what happens is that a young man or young woman in their own home, their parents get a prescription for this, they don't use the entire prescription, it stays there, and they decide, heck, I might as well try this. Or, worse, they take out and they go to sell it because there's great value on the streets for this. So the overprescription of this in every way impacts this crisis in an enormous extent. And that's people who overuse it themselves. It's also people who don't use it, but don't know how to get rid of it safely. And as a result, it winds up hanging around and is available for diversion to either other users directly in their home or to being sold outside of the home.
Thank you, Mr.
I would want to mention one other thing, if I could, on the VA. We took a field visit as a commission to the Lewis Stokes Veterans Hospital in Cleveland. And they are doing some extraordinary things in lowering the opioid use by veterans with alternative therapies and other ways to deal with this issue with our vets. And we've urged in the report that Secretary Shulkin expand that throughout all the veterans hospitals for the very reason you talked about. There are a lot of these vets who know they don't want to take this stuff, but are in real pain from the war wounds that they've suffered defending our country. And they're coming up with alternatives that are really helping the veterans community in Cleveland, and we think it helped the entire country.
Thank you, Mr. Chairman. I yield back.
Gentleman from Missouri is recognized.
Thank you, Governor Christie, for your testimony today. You know, while we have made critical gains in coverage as a result of the ACA, we still have work to do. We need to make sure that the ACA's parity requirement, which requires that insurance benefits for mental health care be comparable to those for physical health care. And I guess that's why you recommended that the DOL must have authority to investigate insurance company. And let me quote the report. It says the commission found that there are commercial insurance barriers to medicated-assisted treatment, despite the fact that such treatment is evidence-based and largely successful. Would you agree that all insurers, both private and public, should work to remove barriers?
Sure, and that's the law in the country. I mean, this is the frustrating thing. Congress passed the Mental Health and Addiction Parity Act, but for reasons that are beyond me, gave the executive branch no ability to enforce it. And so I don't want to be, again, New Jersey cynical, but we're counting on the goodwill of the insurance industry to cover this treatment that's required, but there's no penalty for not doing it. So my view is, as a former prosecutor, the law should be followed. And if Congress's will and the president's will at that time was to make sure that mental health and addiction is treated with parity for physical ailments, then the law should be enforced, sir.
So we need to put more teeth in the Domenici.
You bet. And listen, we had Secretary Acosta at a hearing of the commission, and he asked for this authority. He said, if you give me this authority, I will use it. And Chairman Gowdy, I think, knows that Secretary Acosta is also a former U.S. attorney who served with me during the Bush 43 administration. I know Alex well, and I'm convinced that somebody with his background and experience as a prosecutor in Miami on this issue would be very, very aggressive if the tools were given to them, and I urge Congress to give them the tools.
Thank you for that response. I represent the state of Missouri, and I'm proud of a lot of things, but one issue that I'm not that proud of is that we have a patchwork for a PDMP in Missouri. It may go by county or city, but it's not really statewide, and it's not effective. Talking to law enforcement in Missouri, they tell me that it's really become a pill mill, and it's an attraction for users as well as physicians who want to make profits off of that. Tell me, how is Missouri? How do they compare to the rest of the nation as far as being a problem for law enforcement?
It pains me to say this to you, sir, but it's the worst state in the nation.
Yeah.
It is the only state in the nation without,
I appreciate
without a comprehensive.
We need to be critical of our state.
It is stunning to me that there is a state in this nation any longer that doesn't have a comprehensive prescription drug monitoring program, and that they're not sharing that information with their neighbors. We know that people will go from state to state to be able to fuel this addiction. And one of the not only effective law enforcement tools, but it's also an effective healthcare tool predominantly for our physicians. They can use the PDMP, be able to see when someone comes in presenting with symptoms that might induce them to prescribe. But if they go into the PDMP and see that this patient has had a dozen, 2 dozen, 3 dozen from other doctors' prescriptions for this, they can stop adding to the problem then. So Missouri is a state that is the sole outlier on this issue, and one that is damaging the health and the safety and welfare, in my view, of the people of Missouri.
And I appreciate hearing that, and I will make the effort with our legislature and governor to reinforce it and tell them how much we need to get our act together.
Yes, sir.
Final question is HHS and CMS now get down to the tough work of implementing some of your commission's report. And I understand that they are calling for states to apply for waivers from the IMD exclusion. New Jersey and Utah just got a waiver approved, but as I understand it, CMS has insisted that waivers are budget neutral. So CMS is asking for states to find cuts elsewhere in underfunded behavioral health systems to pay for SUD treatment in residential settings. To me, that doesn't reflect the urgency of this epidemic. Can you talk to us about how New Jersey dealt with it?
Yeah, I think that what we are finding areas, and this is part, I think, of each governor's responsibility, is to find places within the Medicaid program where spending is not being effective. And so I think it's a good start. I think once we become convinced at the state level that we have done what we need to do in terms of cost savings, that then the administration will have to make the next decision, which is to lift budget neutrality requirements from it. You'll notice in our report we do not ask for a waiver of IMD with budget neutrality. We just ask for a waiver of IMD exclusions. That's our ultimate recommendation. But I can tell you in New Jersey that governing is about choosing. And I do believe that given the level of this crisis, I can make the choices as governor that are necessary to make those beds available almost immediately. But there will come a moment when you're cutting into bone and not fat. And when that happens, then I think the broader IMD exclusion is something without budget neutrality that needs to be considered by the administration.
Thank you for your responses. My time is up.
The gentleman from Kentucky is recognized.
Thank you, Chairman Gowdy. And Governor Christie, thank you for being here today to discuss the growing crisis of substance abuse in our country. The opioid epidemic is a particular challenge for my state of Kentucky, where overdose deaths rose by 12.5% last year alone. I appreciate your work as chairman of the President's Commission on Combating Drug Addiction and look forward to working together to make progress on this issue for all the American people. My first question is I would like to discuss the issue of fentanyl, which accounted for nearly half of the overdose deaths in Kentucky last year. Can you briefly discuss the Commission's findings and recommendations related to this especially lethal drug?
Yes, fentanyl and carfentanil is what will take this crisis to its next geometric explosion. because the strength of fentanyl and carfentanil is so beyond normal street heroin that the first usage of it can lead to death, and often does. It's so lethal that law enforcement officers who come to crime scenes where this is have to be careful in terms of the way they deal with the crime scene so they don't contaminate themselves and wind up overdosing. And in the report, we make it very clear that this is a Chinese problem. And we have urged the President and the Secretary of State to make this a priority with the Chinese in the negotiations that they're undergoing right now. China is where most of the fentanyl and carfentanil is coming from. Sometimes, more times than not, we found, and this is why we recommend an increase in border security, not just at the Mexican border, but with the United States Postal Service. The United States Postal Service is delinquent in stopping these drugs. These drugs are being mailed in to the United States, and as are with the other carriers like FedEx and UPS and others. We are not having the level of enforcement we need. And to your point before, Congressman, this is one of those areas where I think we need to be able to step up our efforts at the Postal Service and at DOJ through the DEA to make sure that we're stopping this stuff from coming into the country. But we also need to make very clear to the Chinese that this is an act of war. You are sending this into our country to kill our people. There's no other purpose for this drug. This drug will kill people. And any foreign country, in my view, who is willfully allowing this to be done is committing an act of extraordinary aggression on our country, and it needs to be met with the right type of diplomatic response by the administration and the Secretary of State, and we've urged that in the report.
And I appreciate the work that you've done along with the administration on seeing a recent crackdown in the Chinese manufacturers, and look forward to working with the committee to see what more we can do through the internet and postal systems to try to prevent that. My last question, through legislation like the 21st Century Cures Act, Congress has worked to provide more support and flexibility to states who are on the front lines of this battle. From your experience as governor, as well as your work on the commission, what advice do you have for Congress on how best to support state and local efforts to combat the opioid epidemic, both now and over the long term? And I know you mentioned the $1 billion didn't go very far. You divided up among the 50 states. But as you know, we're in a financial crisis as well in this country. So what advice do you have for Congress?
Well, first off, I think if this battle is going to be won, it's going to be won with the federal government, the state government acting as partners, but with the state governments taking the lead. We're the ones who are on the ground. And as you said, the problem in Kentucky is different than the problem in New Jersey. And the problem here in Maryland is different than the problem in Missouri. I mean, these are state circumstances depending upon all the different ways that you go about enforcement in your state, the ways you go about treatment in your state and its availability. So our view is that this should be accountability block grants, that block grants should be sent to the states for dealing with this crisis, and that Congress should be demanding accountability in return for the block grant. If I'm given a block grant as a governor and I say in New Jersey the best way for me to spend this money is X, and it will show a decrease in deaths, if I show that decrease in deaths, I should continue to get my funding. And if I don't, my funding should be reduced. To force me as a governor to be accountable for what I'm doing. With all due respect to Congress, it's a very difficult job to be able to determine individual programs that are necessary and effective in all 50 states. And so I really believe we have to trust the governors. And because I don't believe this is a partisan issue, I don't think there's a Republican or a Democratic way to combat this. So I think part of this is going to have to be a leap of faith between Congress and the governors to be able to sit down. And I really do believe that if Congress is serious about doing this, and the president, they need to sit down with the governors. They all come to Washington in February. I won't be there, but the rest of them will be. And the fact is that we need to sit down and say, listen to the governors as to what they need, and Congress then needs to make demands on the governors and say, okay, if we're going to be your partners in this and we're going to help you fund this, then what accountability measures are you willing to give us so that we can be accountable in the financial situation we're in, that this money is being spent in a way that's effective to save lives? And that should, in my view, should be the determining factor. If that number, that 64,000, continues to go up, we are failing. When it starts to go down, we're succeeding.
Well, thank you, Governor, and I yield back.
I have not gone yet either, so I'm share this with my colleagues. We want to be a good steward of the governor's time. We also want to be a good steward of the next panel's time. So to the extent we can get it done before the red light comes on, that'd be great for everyone. And with that, I would recognize my friend from Michigan, Ms. Lawrence.
Thank you, Mr. Chairman and Ranking Members Cummings, and thank you, Governor, for being here. You know, there is a saying that in government, if you want to know my priorities, follow my budget. Many of the organizations receiving funding through the Community Mental Health Block Grant, through the Substance Abuse and Mental Health Services, and these fundings provide the wraparound services. We're talking about the access to the drug, but those of us in this room and those who have been on the ground with this know putting those services to transition and nurture a person out of addiction back to a healthy life, training, rehabilitation, case management comes through the substance abuse and mental health services. Unfortunately, the House appropriation bills, which we will vote on this month, proposes cutting funding for the community mental health services block grant by $141 million. In our president's budget, proposed cutting it by 116. Now, the commission, and I've read your report, thank you for it, but you strongly recommend and urge Congress to do their constitutionally delegated duty and appropriate sufficient funds. It is being in Congress, being a former mayor and being in local government, sir, being held accountable for my budgetary decisions. I find I'm complex how we can have this commission, you being appointed, doing all this work, but yet and still what we do in our budget would just cut the legs from under this program. I need you to know in your leadership and in your recommendation to this bipartisan body, this agenda of this budget that cuts the thing that we're saying that we are so passionate about. We have statistics. I wanted to say in Michigan, we have enough drugs, like you said, in the United States to give every person in the state of Michigan 1.8 prescriptions, 1.1 prescription, which is 84 opioid pills for every resident in my state. That's how many prescriptions we write. So, but if we really want to make a difference, if they live, we want to get them off of it. So I need you to comment on that.
Well, listen, I think we were very clear in the report. We believe there needs to be a greater financial commitment at all levels of government to this problem. Now, you know, the fact is there are lots of other things that we can do as well and should be doing that won't cost us anything. So increased medical education, increased requirements of continuing medical education for DEA licensees. There's a lot of different things we can do that don't, but please, what we said in the report, we mean, which is that we do not sufficiently fund these programs now. And we also recommend in the report that there needs to be an evaluation of all the different programs. And you just mentioned one of them, and there are literally dozens and dozens of programs we looked at that are being funded. How effective are they? I can tell you that GAO did 2 reports during the Obama administration that said that these programs were not being effective in stemming the tide. We know that from the sign that's behind all of you with the number of deaths. So I think there's a couple of things that need to be done. One is for us to hold ourselves accountable for all the good ideas we've had in the past. Some of them are good, maybe some of them weren't. Let's reevaluate it and reassign that money to places that we think can be effective. And then there's going to have to be additional funds given. And we make that very clear. I made it clear to the president in my direct conversations with him. And every member of Congress who's asked me about this, I've said, there is no avoiding having to increase funding to deal with this problem. The question is how, and you guys get to make that call.
Mr. Governor, and to the panel, we often hear the thing of repeal and replace the Affordable Care Act. And I equate that to you having a Cadillac and you don't change the oil or you don't rotate the tires, and then when the car doesn't operate, you say that the car is inefficient and you just throw it away. The Affordable Health Care Act is provide essential health benefit services that actually directly go to the mental health parity part. But all we talk about is repeal and replace. And I don't know if you're comfortable talking about this, but I am very comfortable. It is a time for us to have real discussion on this. We talk about the lives that we're losing, and we are so compassionate, and our hearts break when we read the obituaries, but we must do the work. And I want to be that voice in the room while we're talking about this. The action that needs to be taken needs to happen. It's not good enough to get a commission together, write an excellent report if you don't fund it. If you don't look at the Affordable Health Care Act that have those essential services that we're saying eliminate, how are we going to get to where we need to go? Thank you so much. My red light is on.
One thing I would just quickly in response to that would say to you is we need to remember that no matter my position on the Affordable Health Care Act is pretty clear over time, but I won't get into all that. I'll just tell you this. The Affordable Health Care Act insures a fraction of the number of people that private health insurance in this country insures. And yet, Congress is not permitting mental health and addiction parity to be enforced for them. And so, the fact is that we have tens of millions of Americans who work hard every day and are able to obtain health insurance through their employer and pay for a good part of that as well. And they're not getting the benefit of the law on parity either. And so I don't think it's just in talking about the Affordable Health Care Act. We're not enforcing that as to the Affordable Health Care Act. We're not enforcing it as to private insurers. You want to talk about a feel-good piece of legislation, okay? The Mental Health and Addiction Parity Act is a feel-good piece of legislation because when all you do is ask, would you please do this? And if you don't, there's no penalty. We know what happens in those circumstances. And so I think we have to even have a broader discussion about it because it's not just for those people who are covered now under ACA. It is also those people who have been covered under private insurance for a very long time who are not getting the benefit of that law that's now a decade old. We haven't allowed enforcement of that law since the day we passed it. So it seems to me we've got to have an even broader discussion that I think includes all of that. Right.
Professor Raskin.
Mr. Chairman, thank you. Governor Christie, again, welcome to Maryland. I want to, first of all, salute you for the passionate intensity of your leadership of this commission and the way that you have clearly absorbed all of the lessons of it in a powerful way. And I also want to thank you for the comprehensive nature of the recommendations that are in the report, which include messages for us in Congress. And I very much take your point about empowering the Secretary of Labor to act. And I hope that's one of the things that will come out very concretely from today's session. But also there are a whole series of recommendations across the federal government, the Department of Education, the Department of Justice, the National Highway Traffic Safety Administration, HHS, and so on. So I know you're a big Bruce Springsteen fan. Who's the boss now? In other words, who's in charge of implementing all these recommendations across the federal government and being the leader in making sure that these things come to fruition?
Well, first and foremost, the president has to be the leader. He's the person who empowered this commission, and he's the leader of the executive branch of government, and it's his responsibility under the Constitution to make sure that the laws are duly executed. So the buck stops with the President of the United States, and I'm confident that the president is serious about this effort and will put the resources that are necessary to do it.
Can I just follow up on that point? So I was following your work very closely. You came out with the commission report on November the 1st, I think it was. So it was just
Yes, it was.
Earlier this month. Did you come down and have a session with the president and his advisors about everything that's in this report and talk about what the next steps are?
Yes, sir.
Okay, and what came of that meeting? I mean, has he appointed, is there an opioid crisis czar in the White House now?
Not to the best of my knowledge.
Should there be one?
Listen, I think as a governor, the czar thing can sometimes get a little overplayed. I think the fact is the president needs to give direction to his new HHS secretary, because if you look at the recommendations, you're right that they're all across government. That's why at every one of the commission hearings, we had the Deputy Attorney General, we had the Secretary of HHS until there was a change there, and then the Acting Secretary. We had Secretary of Labor, we had the Secretary of Veterans Affairs. All of those individual cabinet officers, I think, need to be empowered to take the section of the report that is theirs and report back to the president on what they're doing on a regular basis to implement it.
But as a governor, you also know if everyone's responsible, no one's responsible in some sense.
The president is responsible.
Okay.
And as
well,
governor,
then, with all respect to the president, then, I mean, we have tweets about people kneeling during the playing of the national anthem. We have tweets about who got the Americans out of China from shoplifting charges. I haven't seen any tweets about the opioid crisis, and I don't see the kind of passionate intensity of leadership that we need to deal with what you describe as the equivalent of a 9/11 every 2 weeks in the United States of America.
Well, let me respectfully say this. Before this president, you didn't see a national commission on this problem. And this problem didn't just start on January 20th of 2017. This problem was building for years before this. And neither President Obama nor President Bush empowered a national commission to come up with recommendations, put absolutely no restrictions on that national commission on what recommendations I could make. This president is the president who's declared a national emergency. This president is the one who's begun to grant IMD waivers. This president is the one who is taking the leadership on this. So listen.
But I'm just asking about constructively moving forward. Well, how do we make sure that there's dozens of recommendations in here? How do we make sure that they actually get into practice at every level of government?
There's a few ways. First of all, the President of the United States is the chief executive, and he should require of those men and women who serve in the cabinet offices that he has appointed them to that are covered in this report to report to him on the progress they're making in implementing the report. I don't think that requires another person sitting in an office in the executive office building, sending out emails, with all due respect. As a governor, I hire cabinet people. Those cabinet people are supposed to run those departments, and I think that's what the president's going to require of them. But more importantly, what they have seen is that this president is the first president who has elevated this to this level. And he deserves great credit for that. And I know it's very fashionable right now in lots of different corners to be critical of all those different things. And I've been critical of some of it myself. But I don't believe it's right at this moment in time to be critical of the president's efforts in this regard. And he will be held to account for what he produces. But I would also say that Congress has to step up as well. And this is not just the president's responsibility, but every person sitting up here and every other member of the 535 of you know about this problem. You didn't need my report. My report gives you some good recommendations, but what you know is that people are dying in your district every day. And so I'd say, what are members of Congress doing as well to demand that this be done? If that happens, then there will be a cacophony in that city, which will force action from both the executive and the legislative branch.
Thank you, Mr. Chairman.
Gentleman from Vermont, Mr. Welch.
I'll try to be quick in light of your admonition. Number one, Governor Christie, greetings from Governor Shumlin. He gave a State of the State in 2014 where it was totally dedicated to the opioid crisis, and I remember many of my colleagues wondered why in the world he would do that, and then started acknowledging that this was a huge problem in their states. Second, we need concrete actions. There is bipartisan concern about this issue. There's bipartisan conflict about spending on just about anything. But you outlined some concrete things we could do. For instance, if we can't appropriate money, which I'd be in favor of, many people here would be, we can at least deal with the drug company ripoffs. And you acknowledge that cost increase that is really becoming an enormous burden on our local communities that are on the front lines of trying to address this. So I want to ask you this question, and then I'll stop. The ideal outcome here is that Congress would step up and find the areas where we can act that would make a difference, like addressing the cost issue, like the prescription issue. And my question to you is, what would be your advice to this committee, knowing that we're divided on many issues, but we have a common concern about this horrible scourge in our communities? What are the three things you would recommend for us to do?
You're asking me to take 65 recommendations and boil it down to 3. I'm pretty good, but I'm not that good. I would just tell you this, that the first thing we need to make sure we do on the supply side is to nip this fentanyl and carfentanil problem in the bud. If we don't, 64,000 is going to look like the good old days. And so our interaction with the Chinese on this needs to be unequivocal. And our ability to invest in making sure that we're stopping this as best we can from coming in to our country is going to be enormously important, because fentanyl and carfentanil is going to make heroin and prescription opioids look like child's play. Secondly, I'd say that the issue of education of our medical community, and I include the pharmaceutical companies in this, about the danger of these drugs, and having a real national conversation on the cost benefit of using these drugs has to happen. With this many deaths, and I understand pain is real, and the chairman is right in his recommendation on that we need to deal with those folks who need to get to work every day and suffer from chronic pain. But I can tell you, we're losing that fight. We're losing that fight because that home builder can't go to work if he's dead. And so, we need to try to have a conversation about that with our medical community and get them more attuned to the fact that this is killing people. Third, I'd say we have to fund greater treatment in this country. We just have to. And so if you made me come down to three, I'd say fentanyl and carfentanil and the interaction with the Chinese and our own law enforcement has to be strengthened, and our communication to the Chinese on this has to be unequivocal and see it as an attack on our country and its people. But secondly, we need to work on medical education, because our medical community is not educated enough at this time on this issue across the country. And that's why we also recommend things like, distance, treatment of folks who are in rural areas, can't get to a physician, being able to do that stuff in different ways is very important to do. And then lastly, we have underfunded treatment in this country, and we need to make treatment more available, folks. I think it was, as Member Cummings said in his remarks, quoting the report, when 10.6% of the people who need treatment are getting treatment, we need to do better. And I think if you maybe boil down 65 to 3, I'd go with those three, although I'm sure when I leave, I'll kick myself for having not picked a different one.
Thank you very much. I yield back. Yeah. I yield to Mr.
Just one question. I told the chairman just a moment ago that this is one of your finest moments. And I really mean that. And I got to ask this question because I think it's critical. How can you, Governor, with your passion and your full understanding and embracing of this issue, how can you help us bridge the gap between Republicans and Democrats so that we can get something done on this? And I don't mean to put you on the spot, but I mean, it's a critical moment. And when you just said what you said about fentanyl, we got to do something. And you seem to have pulled it all together and come out with a very balanced report so that we can be effective and efficient. That's all.
Well, I appreciate the opportunity. I don't feel burdened by it at all and by your question. The fact is that I'll play any role that leaders of both the Congress and the administration want me to play as a private citizen in 49 days to be able to continue this fight. Mr. Cummings, this is something that began to be a passion for me in 1995, when, as a local county official, I was brought to a drug treatment center in my county for adolescents. And I saw what was going on there, and the priest who started this treatment facility said to me at the end of my visit, "Chris, this is something you're going to want to be involved in for the rest of your life." Now, in 1995, I was 32 years old. The rest of my life seemed a lot longer than it does right now. But I said to him, "Father, with all due respect, I mean, why am I going to want to be involved in this the rest of my life?" And he said, "Because you just walked out of a place where God makes miracles happen on earth." And from that moment on, Mr. Cummings, I've been hooked on this problem and on saving lives. And so you can see what happened in New Jersey. I've worked as a Republican governor every one of my 2,920 days with a Democratic legislature and with broad majorities. Yet the package that we've done on this twice has passed overwhelmingly bipartisan majorities. And I gave my state of the state in 2016 on this with a package of reforms to insurance, to pharmaceutical companies, all things that are difficult things to do, they passed within 30 days and were signed. I am happy at any time, sir, at the encouragement of the chairman or of you to come and speak and meet with anyone and to use my relationship with the president, which goes back 15 years, to encourage people to say, this is the new water's edge in our nation's conversation. We have to end the politics here. We have to compromise with each other. There are going to be some things that people on my side of the aisle are going to have to vote to fund that they may have some concerns about. And there's some flexibility and trust that folks on your side of the aisle may have to give to governors that you're not normally accustomed to doing. But I think I can speak to that directly, and you have my word that I will not only speak out and continue to speak out publicly, but I'll play whatever role you two gentlemen want me to play in helping to do this. And the president knows that I feel exactly the same way. And I'm one of the folks who's known him for 15 years. So when he needs to hear some truth, he comes to New Jersey not just to play golf. Let's put it that way. Thank you, sir.
Gentleman from Maryland, recognized.
Thank you, Mr. Chairman, and thanks for the opportunity to sit in on the hearing today. Governor, thank you for your testimony, and thank you for the report of the commission, which I think is outstanding and has a myriad of very positive recommendations that we probably need to prioritize so that we can make forward progress, but I think a lot of the building blocks are there. We're very proud of the efforts here in Baltimore that our health commissioner, Leanna Wen, who we'll hear from shortly, has undertaken, that healthcare providers and institutions like Johns Hopkins and others are undertaking to change the trajectory on this. It's obviously a heavy lift, but these recommendations will help. I want to echo Congressman Cummings' concern about making sure that naloxone is available in the way that it should be and that there's not price gouging going on around that, and I think that does need a closer look. I was able, and I want to thank you for the recommendation around co-prescribing of naloxone. We were able to get included in one of the bills that was passed last year, the Comprehensive Addiction Recovery Act, a proposal for a demonstration project on co-prescribing of naloxone to examine best practices around that. Your recommendations, in a sense, are running alongside that in a very positive way, so we thank you for that. My question is this. I would imagine that you don't think yet that the sense of urgency that needs to be in the country around this issue is there. But it's changing. And as I move around in my district, I'm sure this is the experience of others, not only are you hearing about these tragedies that raise your awareness, but you're also hearing people say things like, I went to my doctor the other day, I went to the dentist, and they gave me a prescription for this OxyContin or something like that, and all I really needed was Tylenol. So patients are starting to step back from this. So something's getting to them. There's beginning to be a level of public awareness around this. When will you look at the situation based on your experience and being involved with this commission, and what will you see? What will be the indications to you that the level of urgency is where it needs to be among policymakers, that the level of education and awareness out in the public is where it needs to be? Is it PSAs coming across the airwaves in a way that matches election time in a swing election somewhere? Is it the president getting a briefing every Monday morning on what the status is with all the steps that are being taken with respect to addressing this crisis? What are the indicators that you're looking for to say to yourself, we're starting to get it here?
It's a really good question, Congressman. Thank you. So I've been asked this before. Someone in their remarks, I forget which member said it, talked about this epidemic being in greater numbers of deaths now than the AIDS crisis at the peak of the AIDS crisis in the mid-1980s. I was alive then, and a young adult. And here's what I think. Where are the marches? See, I remember the AIDS epidemic, and I remember marches in every major city in this country and in Washington, D.C., with people marching to say the government must do something to find a way to stem the deaths. And in this crisis, there are many, many, many more people impacted than were impacted in the AIDS crisis. Yet we have no marching. And I'll tell you that I think we will have seen that we've begun to remove the stigma of this disease when the people who are impacted are willing to show their face and march and demand from their government a response. And I believe they don't march today because they are ashamed to march, because they don't want to be identified. I'm not talking about everybody, but I'm talking about mass numbers. They don't want to march. They don't want to be identified as this having happened in their family, to their loved one. And I think that that's why we recommended a massive national advertising campaign beyond PSAs. I will tell you, in New Jersey, in this year, we will spend $50 million on an advertising campaign in my state to remove stigma and to let people know how to get treatment. $50 million of state money. And the reason we're doing it is because I don't want people to be stigmatized anymore for this, and to avoid treatment and avoid asking for help and avoid demanding that there be something done about this. I will tell you one quick story. My mother was an addict. She was addicted to nicotine. She began smoking when she was 16 years old, and she smoked for 55 years, and she tried everything she could to quit, and she couldn't. And when she inevitably, it seemed, was diagnosed with lung cancer at the age of 71, nobody said to me, well, your mother was smoking for 55 years. She's known since 1964 that it could cause cancer. She's getting what she deserved. No one said that. People said, oh, we're so sorry for your mom. What can we do to help? Let's recommend doctors or treatments. Did she go to this hospital or that hospital? We're praying for you. They came and visited her. They consoled her. They encouraged her. And I felt no shame in telling people that my mother had lung cancer and that her lung cancer was caused by smoking. I want to ask you, sir, if my mother was a heroin addict, would I have done the same thing? And would all those people have come to her aid and recommended treatments and help? Would my dad have been willing to ask for that? I'll know that we're bringing the urgency to this when those barriers go away. When people march to demand that Congress and the president and their government, along with our private sector, find treatments to treat people who are addicted and to find ways for them not to get addicted in the first place by alternative medicines. I'll believe it when people are marching and showing their faces. And when that happens, we'll know that we're on our way to a solution. And that's what I firmly believe in my heart, and I believe the stigma is causing death every day, almost as much as the drug is itself.
Thanks. I yield back. Gentleman from Maryland is recognized.
Yes, thank you, Chairman Gowdy, and Ranking Member Cummings. Thank you for having this hearing in Baltimore, such an important hearing. To all our members on both sides of the aisle, welcome to Baltimore. Governor, and I want to acknowledge Dr. Wynn, who has done a lot in the Baltimore area. Governor, I think you're at the right place at the right time. You were in local government. You were a prosecutor. You managed a major jurisdiction. That's kind of my life, local government and managing a jurisdiction, except I'm in Congress and you're a governor. And I really appreciate the fact that you have made this one of your highest priorities. When you leave office, probably it will dominate your life for a while. Now, there are a couple suggestions that I do have, though, and to make sure that we pull all this together. First thing, when you have a major crisis, you've got to identify the problem. And I think these hearings, we understand it with the deaths throughout the country. It's a national issue. It's just not in urban areas, rural areas, everywhere. But the part that I'm interested in, I'm an appropriator. And, one of the issues that we have to deal with is clearly money. And, we have to have that. And there's been a lot of money put into this. There are other areas as far as treatment and drug treatment, doctors, nurses, treatment centers, all those type of things. But I know in your report, which is a good report, I haven't read it, but I've heard it and I've been briefed on it, There are a lot of recommendations, and and when you have that many recommendations, you have to pick priorities. But I think for us to get to the level, those of us who are appropriators, we're going to have to find out what your recommendations are for money, especially from the federal government. We have to have a number, and I would hope that your committee or your staff on your committee can start putting together a report. Now, the second thing, there's no question, you said the Congress maintains the power of the purse. But in this situation, the president who has within his power as president to free up funding as well. And I'm glad the president has made this a priority, but everything in life you have to have follow through. And with your relationship, I didn't know you knew the president for 15 years, that's even better. And with your tenacity, with your experience in all the areas that I talked about, I would like to know what your plan would be to work with his advisors, his administration, to make sure we find out where we are as far as the money. Our governor, and I praise him, Governor Hogan has dedicated $10 million per year for the next 5 years to fight this epidemic. I think other governors throughout the country need to do that too, whether Republican or Democrat. And this sure is not a partisan issue. If there's anything that's not partisan, this can't be the case. So my question to you is, first thing, can you decide what the recommendations would be as far as funding are concerned? When we find that number, we will work with you. I will pledge to work with you as other appropriators, Democrats and Republicans, to find a way to get Congress to fund this issue and also to get the president. Congresswoman Brenda Lawrence made a comment about certain cuts that are already there. So if the president has made this such a high priority, we're going to have to influence him. We're going to have to find a way to get him to make this a high priority to go forward in what we need to do.
Sure. A few things. I think when you say the commission or my staff, I want to be clear. My staff is like sitting right over there. My chief of staff in the governor's office was the main staffer. We were not given staff on this. We had some support from ONDCP, but I will tell you that the work that you see in that report is the product of the commissioners.
Okay.
And so we did not get into an amount of money. And quite frankly, I didn't think it was our province to do that. We laid out the priorities that we believe are very important. And we believe that every one of those are important priorities. Now, I know from personal experience that governing is choosing. But the choosing now needs to be done by the president and the Congress, not by an unelected commission. We've laid out all the things that we think need to be done in both near term and long term. Now, I really believe it's up to the leadership of the Congress and the president, along with the appropriate cabinet members, to sit down and to say, how do we implement this plan? How do we want to do that? And I don't think, listen, I've done this stuff as a governor, but no one elected me to do this. And I really believe that all of you are the ones who have both the authority and the responsibility to do it. I'm happy to identify the problem and identify solutions and bring a practical opinion to it. But I don't believe it's in my realm to talk about how much.
I respect you, what you've done, but you're the man. And if you can't do it, nobody can.
I'm going to have you call my wife and tell her that.
You have,
be helpful.
Well, you have the expertise. You're an advocate. You've committed. But if you don't have the money, it's not going to work.
I agree with you.
So we need you to be not only the advocate, we need you to be the lobbyist. We will work with you. I will, Democrat and Republican staff, I guarantee you, on the Appropriations Committee on the House side, will come together. But we need your expertise and your advocacy, especially when it comes to this president.
Sure. Well, listen, as I said to both Mr. Cummings and Chairman Gowdy, I am and will continue to be available to all of the folks on this committee and other members of Congress who care passionately about this issue to give you my advice, my counsel, my opinions, and to be an advocate. I'm going to continue to be an advocate, no matter who's in the Congress, no matter who's in the White House. I've been an advocate on this issue for 22 years. I'm going to continue to be an advocate on this issue because in my heart, I believe that the most important role of government is to protect the health, safety, and welfare of its citizens. And this is right at the core of that. So I don't know if I like the phrase lobbyist that you threw in there at the end, but I will certainly be an advocate.
Persuader.
Yeah, I'll be an advocate for this. And I've been an advocate with the president all along, and I'll continue to be.
My time is up, but my staff, I want to reach out to your staff to find a way how we can start working on the numbers.
Excellent.
That's end game.
Look forward to it, sir.
Okay.
Gentleman from Maryland yields back. Governor, I want to thank you on behalf of everybody for not just for being here and sharing your perspective today, but for the hard work that the commission did. I go last when it comes to questioning, and I want you to, while we appreciate the audience that is here, they would be in the upper echelons in terms of engagement and education. I want you to think of broader audience, broader jury. Our fellow citizens that have heard about the epidemic, perhaps someone close to their family has been touched by it, but they don't live and breathe it every day. As I listen to your opening, you can put physicians, I guess, in one of three categories. The vast majority of physicians are incredibly well-intentioned, and they're well-trained, and they're well-educated, and they do it the right way for the right reasons. And then you have a group that is equally well-intentioned, but they lack the education on it. And you made reference to continuing legal education, continuing medical education. There is that group, and I don't know how big it is. Our perspective is swayed by being prosecutors. There is that group that is profiting from people's addiction. And I don't see the diversion cases being prosecuted like I did in olden days. Am I missing it? Did y'all find it?
No, I don't think you're missing it. I do think that there has been, over the course of the last decade or so, a de-emphasis on that priority, and I think it's a mistake. I often think, Mr. Chairman, that folks believe that to emphasize one issue is to de-emphasize another, right? So in New Jersey, for instance, we've done broad criminal justice reform that has lowered our prison population more than any state in the country. And during my time as governor, we've closed 2 state prisons. Yet our crime rate is down significantly in our state. That doesn't mean that I don't want to see my Attorney General continuing, and he has, to continually aggressively pursue the drug dealers in our state who are killing our people. I think that sometimes justice departments, which we've both been members of, think that if you're in favor of criminal justice reform, you can't be in favor of aggressive prosecution of criminals. Or if you're in favor of aggressive prosecution of criminals, you can't be for criminal justice reform. I don't believe that. And I think as a governor, it's taught me even more than as a prosecutor. The federal government, in my view, over the last decade has dropped the ball on these cases. And I think that it is contributing, not causing, but contributing to the problem that we have today. And that's why I'm not in favor of shortening the leg on the stool of enforcement and interdiction. We need to continue to do that and do it aggressively. I've shared that opinion with General Sessions, and I believe he understands that piece of it. But that message has to get out to the U.S. attorneys. And that can only come from the Attorney General and the Deputy Attorney General. You and I both know. And when you're a U.S. attorney, it's kind of like being a captain of a ship out at sea. You know, sometimes the radio works from the shore, and sometimes maybe you can't hear it quite as loudly. We need to make sure the radio is working on this one, and that U.S. attorneys are not given an option, but are given a directive from their boss, the Attorney General of the United States, that these are important cases to do. That doesn't lessen our commitment to providing more treatment. It doesn't lessen our commitment to confronting the Chinese on what they're doing and using our foreign policy tools in addition to law enforcement to doing that. And it doesn't mean that we don't believe that education and prevention are really important. We didn't talk about that today. But let me say, in conclusion here, from my perspective, that if we don't start talking to our children in the middle school about this issue, we will lose them. And it's frightening to me as a father to think that my 11 and 12-year-old daughter or son needs to be spoken to about this issue in stark terms, but they do. And we can't do it anymore. I saw from the Department of Education, they were very proud. They showed me when I first became chairman of the commission, we have this new pamphlet that we're going to be giving out in schools on this issue. And I looked at it and I said, so listen, it's a great pamphlet. I read it, a lot of good information. I said, if my kids got this pamphlet, it would go in their backpack. By the end of the school year, it would be all the way at the bottom of their backpack, and they'd never read it. Because if it's not on here, they don't read it. We need to modernize the way we're educating our children. We should be demanding of companies like Google and Facebook, who are such predominant players in communication today to our young people, that they step up to the plate and start educating our kids on the things that we need to do. So what I'd say to you is, We have dropped the ball, in my view, in the last decade, since I've left the Justice Department in 2008, in doing these cases. We need to do them to slow the supply, but we also need to make sure that we're doing those other things as well. And this is the bipartisan nature of it, and I believe that Mr. Cummings agrees with this as well. We've got to get rid of our old barriers on this issue, to think that if you're for one thing, you must be reflexively against the other, or vice versa. We can do both, and we must do both. And there are people of goodwill and great experience who are ready to help to do this. And I hope that they're called upon to do it, and I count myself as one of them, and I will allow myself to be called upon to do it. And so I think you make a very good point, Mr. Chairman, and I think we need to make sure that we don't get caught in the trap of mutual exclusivity. It's a trap that'll lead to failure, and failure we can't afford.
Well, I want to finish up with drug court because we agree on that. If you want to not only have your own life changed, but see other people's lives change, attend a graduation for a drug court. That graduation ceremony will be with you for the rest of your life. And I want to mention one kind of a niche issue there at the end. I also want you to address what barriers did you find, if any, for the pharmaceutical alternatives, non-habituating, non-addictive, pharmaceutical alternatives. What are the barriers to either having them researched, developed, or to market?
They don't believe they're going to be profitable. I think that's the single biggest barrier to it. And that's why I believe bringing NIH in as a partner to be a fair broker of the compounds and say which ones are most effective, and let's move those most effective ones to the front of the line and allow them to go to market, and let's see how it goes. What I say, and listen, you know that New Jersey has more pharmaceutical companies than any state in the country. And so I'm very sensitive to the importance of the pharmaceutical industry, the role that they play in our country as an economic driver in addition to being a healer. And I'm an advocate for the pharmaceutical industry. But what I reminded my friends in the pharmaceutical industry is they have a social responsibility that goes along with that. And that to stand by and not develop these compounds purely on the basis of concern about profitability is to, in my view, walk away from part of your social responsibility as a corporate citizen in this country. Now, NIH needs, I think, to be a fair broker in all this so that the right compounds get the right money spent on them to develop them. But what I heard from them was the biggest concern was an issue of, with the R&D money that they have available, is this the best way to spend that money for our shareholders? And that's an absolutely legitimate fiduciary concern that they need to have under our laws and our system of our economic system. But they also have a social responsibility as well. And so what I would say, and what we did say to the pharmaceutical companies, is would you trust NIH to be a fair broker on saying, okay, all 43 of these compounds don't need to be developed, but these 5 have real potential to be non-addictive pain relief and or great medication-assisted treatment to help those who are already addicted. And the pharmaceutical companies at that meeting in New Jersey agreed to submit their compounds to NIH. What we need to make sure of now is that NIH has the funding to make sure that they complete that job. If they do, I know Dr. Collins is really committed to this. If they do, we're going to get some of those compounds onto the market, and that's going to help significantly, because I know physicians would much rather prescribe a pain reliever that is non-addictive but effective rather than one that is addictive.
You mentioned the phrase social responsibility. This would be my last point. In addition to being a colleague, one of my favorite colleagues in the entire body, Peter Welch, is also a former public defender. And his clients would have been incredibly fortunate to have him. In South Carolina, I saw sometimes in the state system, public defenders would opt for straight probation as opposed to drug court because it was easier. Now, that is not in their client's best interest. Their client will remain an addict. But they're right. Straight probation is easier than drug court. How do we develop around the grant strategy incenting the defense attorney, the public defender, to encourage their client to go get help as opposed to just being on probation for the next 12 months and remaining an addict?
Well, let me tell you, in New Jersey, what we did was we took away the option. You don't have the option of probation anymore. Your option is this: go to treatment or go to jail. Now, when given that option, it's kind of the gentle encouragement I'm known for, Mr. Chairman. it's, you know, and we had a lot of people in our state who were opposed to that, said, how dare you do that? If they're not ready, they shouldn't go. I said, I've never met an addict who's ready. I've never met an addict who's ready. I've done interventions. I've never seen I had a great friend of mine who sat there and argued with me that I was wrong, that he was addicted. And he didn't need treatment. He was fine. Well, he's dead now. And the fact is, I've never met an addict who's ready. So I think one of the things that you can work on from a grant structure perspective is to say that we want to encourage those programs that don't give an option. That your option, you don't have a probation option, because I know exactly what you're talking about. That was happening in my state before we passed this law. Now defense attorneys have a really easy equation to give their clients. You can go to drug court and go into treatment, or you can go to state prison. And what we're finding is most people are choosing treatment, and even when they don't think they're ready. And what's happened, you talk about drug court graduations, the miracle of those drug court graduations is, in my mind, not young men and women and older men and women that I'm sitting with on stage. It's looking out in the audience at their families. Their lives are hopeful again. Their eyes are lit with joy for the restoration of a life that they initially brought onto the earth and which they had almost given up on, right? So, you know, from my perspective, the drug court and why I advocated for every federal district in this country is because I've watched it change lives, and so have you. And there's no reason, even though there are fewer cases on the federal level that would be appropriate than on the state level, there's no reason that we should have our federal prisons filled with people who would be better off being treated for themselves and for us as a society. Because the recidivism rate, as you know, for drug court graduates goes down significantly. And that's what we all want anyway. We'd much rather spend less money on corrections, on BOP, than we would on other issues that are confronting our country in a time of limited resources. If we can lower the prison population like we've done in New Jersey and close 2 state prisons in 8 years, I defy you to find any other state in America that's closing state prisons with a crime reduction. And it's because we're treating folks who have this problem like they have a disease, not like they have a moral failing.
Well, thank you for your passion and your expertise, and I know Mr. Cummings would want to thank you also as we transition from your panel to the next panel. Thank you on behalf of
Mr. Chairman, thank you very much. Mr. Cummings, thank you for inviting me.
Mr. Governor, thank you very much. Just one thing, our good colleague from Maryland, Mr. Delaney, has a phrase that I wish I had invented. He said, the cost of doing nothing is never nothing. And you've given us a blueprint. Now we've got to act. Thank you very much.
Thank you, sir. Appreciate it very much. Thank you, sir.
Thanks.
Appreciate it.
You know, I'm the CMO of the largest methadone clinic in the country.